Welcome to the 2022 CGA-IGC podcast series brought to you by the Education Committee. This season, we'll be hosting a virtual journal club. Each episode will highlight a recently published journal article that is important in the field of hereditary gastrointestinal cancer and feature an interview with one of the article's authors. Keep listening to find out more about this episode's host, guest, and featured article. My name is Josh Sommovilla. I'm a colorectal surgeon at the Cleveland Clinic, where I work as part of the Sanford Weiss Center for Hereditary Colorectal Neoplasia Syndromes. I will be your host for this episode. During today's podcast, I have two esteemed guests, both also colorectal surgeons. I'll be speaking with Mohammad Abbas, an assistant professor of surgery at Northwestern. Also joining us is Matthew Kalady, director of the Division of Colon and Rectal Surgery at Ohio State University. Drs. Abbas and Kalady recently published an article in the January 2022 issue of Diseases of the Colon and Rectum entitled Evaluation of Urinalysis-Based Screening for Urothelial Carcinoma in Patients with Lynch Syndrome. This paper examined the utility of urinalysis as a screening tool for urothelial cancer using data from patients followed for Lynch syndrome at the Cleveland Clinic's Weiss Center for Hereditary Colorectal Cancer Syndromes. Mo and Matt, thank you so much for joining the podcast. There's really nothing quite like three colorectal surgeons getting together to talk about urothelial cancers. So Mo, why don't you get started? And if you don't mind, could you tell us a little bit more about where the idea for this article came from and what your team hoped to show?
Yes, thanks for having us, Josh. So the idea of the paper started initially 2 years before I came to the Sanford Weiss Center, and it was between Dr. Harabi, Dr. Kalady, and the rest of the team. And they wanted to look at the quality of our screening and surveillance programs. So we had looked at our upper GI screening, lower GI screening, and we decided to look at the quality of the urine analysis we're doing. And that's where the initial thought came from. When I joined the team to look into this study, we were just looking into our paper and just trying to see what are the details of those 204 patients that we found. And we wanted to pinpoint what's the positive predictive value of this screening test.
And Mo and Dr. Kalady, maybe you can comment on this as well. In your experience taking care of Lynch syndrome patients, was there an inkling or a prediction that you had thinking about the utility of urinalysis as it applies to screening for urothelial cancers?
When we first started doing this, I think my impression was that urinalysis was actually a pretty good study. But then we saw cases over the years where we were getting positive tests and nothing was really happening with them. They all ended up being negative as we did a lot more aggressive screening. And it caused a lot of angst among the patients because they thought something was bad. But then when they got a cystoscopy or CT urogram or other kind of evaluations, and then time passed by, they were fine. It might have been kidney stones or some other thing. So from that standpoint, the positive things weren't helping us. And then unfortunately, we had a couple urothelial cancers that we picked up. And we went back and looked to say, were we missing the boat here? And a lot of those people actually had a urinalysis within 6 months or a year of developing the cancer, which was normal. So it didn't seem to be a great test that way either. So what we wanted to do is kind of go back and look at our experience and actually put some numbers behind it instead of this anecdotal experience and see what we could kind of figure out more formally.
So Mo, could you just talk a little bit about what the screening protocols that you were using for the patients who were part of this study and what you ended up finding when you looked at the outcomes of that screening protocol?
Yeah, so before the study, our standard protocol was all patients with Lynch syndrome, disregarding what mutation you had, you would get a urine analysis. And based on the finding of the urine analysis, if you had any microscopic hematuria, you would just go and we'll do like a reflex cytology test to see what's going on. When we looked at our population, we had 204 patients that we had consecutive retrospective urine analysis on them. And then out of those 204 patients, 19 patients had a positive UA based on our standard, which was just having a microscopic hematuria. Based on the findings, we would send those 19 patients to meet with one of our urologists. We had a urologist in our team that was focusing on those patients, and they'll get really aggressive surveillance or screening. They'll get a cystoscopy or a CT cystogram and on the go. Those 19 patients over time, none of them proved that they've had any urothelial cancer. So like Dr. Kalady was mentioning, those patients would get anxious about this test. Now there's a referral to see another surgeon. They're getting more tests done, but really their surveillance was negative. The striking part was the 5 patients that we found that had a urothelial cancer. Those 5 patients, all of them prior to their diagnosis, have had a negative UA. And then they would show up over the next following year with gross hematuria and they'll have a cancer. Me and the team and Dr. Kalady looked into the data too, a lot of time just trying to make sure that like what happened with the UAs prior diagnosis of cancer. And really all their UAs were negative, and they just presented one day with a gross blood in their urine, and then that led to the diagnosis.
Yeah, I think in those 5 patients, I think 3 of them, their UA was even within the last 5 or 6 months before the development of gross hematuria and the cancer diagnosis, which is really astounding. So for this specific problem in Lynch syndrome patients, if you look at the NCCN guidelines, they're very vague about what we should do to screen for urothelial cancers in Lynch syndrome patients. But the only test that they really mention as a possible screening tool is urinalysis. And it's kind of hedged language that's used regarding the utility for it, but it's at least mentioned and nothing else is mentioned. So when you think about the results of this study, how does that change your thinking about the utility of urinalysis as a screening tool for all patients with Lynch syndrome?
I definitely don't think it's a very strong test. First of all, guidelines are guidelines. It's what people think should be done. And a lot of times, I mean, obviously the NCCN is a very strong group, and the experts who present those guidelines and develop the guidelines are very experienced and do the best they can on the literature, but there's not a lot of literature out there on some of these things, and the tests aren't that very strong. So I think they're vague and kind of non-committal, as you said, because the data is kind of vague and non-committal. Urinalysis, the way I've always looked at this, and I think the same thing probably too with the experts, is that urinalysis is non-invasive, it's cheap, you don't really mind doing it, it's very simple to do. So if it gives us any information, why not just do it? And I agree with that. But then when we looked at our data, it's not a great test. And then having a false positive also causes some problems as well. It goes down that line of getting more tests, more expensive things, more invasive tests that actually don't yield a whole lot. So in my own practice, I have not kept getting urinalysis anymore on Lynch syndrome patients. There are subsets. Our study wasn't a huge study, a decent number, but more studies need to get looked at, or more studies need to be done. We need to do broader numbers to really say that this is real. I think the trends are definitely there. But the subsets who have higher incidence of urinary tract cancers are the MSH2 patients, particularly older males with MSH2, and then family history. So those people, I still will get a urinalysis, but I'll send them actually to urology too, regardless of what the analysis says. I think it's really, really important to work as a team. Our work was a team model. We have great nursing coordinators, fellows, GI people, and then we have all the subspecialties as well, along with the surgeon. So urologist and gyn-onc and dermatology and everybody else that kind of takes care of that aspect of Lynch is all part of our center and works together. So we have a urology specialist who's really into this. Steve Campbell is the author on the paper from urology. So we'd send to him, and then he would kind of guide the management of things. So I think the subsets of people still need advanced screening, but the general population of Lynch and all comers probably doesn't make a lot of sense to do UA.
I think that one of the encouraging things about this study is that even though UA wasn't very sensitive at screening for cancers, the 5 patients who did develop cancers did so at a relatively early stage and seemed like the disease was curable by surgery by the time they developed gross hematuria. Mo, does that knowledge affect at all what you think about the utility of utilizing some of the more expensive or invasive tests as screening measures, that they might not be worthwhile in patients who, even if they develop gross hematuria prior to their diagnosis, at least in a small number, were able to have relatively early stage disease?
I mean, I think that one of the good things or cool things about this paper is it taught us, like, you can't treat all patients with Lynch syndrome the same. We know that the MSH2 patients have a higher risk for those cancers, but also you keep an eye on the family history of the other mutations. If they have a strong family history of urothelial cancer, then you can say, okay, I'm going to screen those patients with UA, and then I'm going to send them to see urology soon so they can decide on which tests they're going to start doing. I think those 5 patients were alarmed about the gross blood in their urine because they knew they're at high risk. So that all goes back to your counseling in clinic and telling them, this is what you watch out for. You're still at risk for those cancers. When it comes to me seeing patients now, like, I remember seeing a couple of patients in clinic that came from the community that are getting annual cystoscopies. I don't think that's a good way to use resources, especially in the US. And the second thing is, when we look at those patients at large, like Dr. Kalady said, you want to find a test that doesn't cause also anxiety and problems when you're screening them every year.
I just want to add on to those comments. First of all, the whole point of detecting cancers in Lynch, or any cancer for that matter, is getting it at an early stage where you can still intervene, or getting it at a precancerous stage. At some point, these things are developing and we're just not seeing them. So we have to get better at how do we pick up and how do we screen. I still think the best kind of ways now are direct imaging, either with CT or cystoscopy, looking at the mucosa and seeing if there's something there. I don't want to do invasive procedures in everybody, but I think we find that subset, there's still going to be somebody who should get that done. The other point that you bring up, Josh, is you say, they all have gross hematuria. It's an important question or important topic to bring up to your patients and say, you're at risk for getting urinary tract cancers if you have any kind of symptoms. If you start seeing blood in your urine, that's something you need to tell us right away. Sometimes people may not think that, or they think it's there, or it comes and goes, and they don't evaluate it any further. So letting everybody know that this is a risk. And if you see these symptoms X, Y, and Z, then you need to let us know right away so we can evaluate it fast.
Thanks. That's a great point. You mentioned that this is one thing that we need to get better at detecting. Are there any things that you see on the horizon as future developments for improved screening tools for urothelial cancers?
Unfortunately, there's no great test right now. I think if there were, we'd all be jumping on it. Detecting early cancers of all systems in Lynch is a huge topic right now, obviously, and it's been a huge topic forever. Some of the technologies that have come down the line that may be beneficial for this is the circulating tumor DNA and looking at minimal residual disease for recurrence, or can we pick up those? We use those kind of tests to pick up things as a screening to begin with. So maybe down the road, as we start figuring out what do these tumors look like, can we start doing blood tests that might pick this up as a screening process that's more sensitive than what we're already having? That would be kind of my only thought towards what that looks like right now.
Well, thank you very much. And thank you both for joining for this really interesting podcast episode. I encourage everybody to check out your paper in, again, the January 2022 issue of Diseases of the Colon and Rectum. It's been another great episode of the Education Committee's podcast series, and I encourage you all to join us again next time.
Josh, thanks so much, friend, and thanks to the CGA for letting us talk tonight.